Hi, and welcome. I'm Heather Frierson, Internal Communications Manager here at University Health. Thank you for joining us today for this webinar on pulmonary arterial hypertension, or PAH, an uncommon but serious condition that greatly impacts patients' lives. We're pleased to be joined by Dr. Azzam Paroya, who will cover the pathophysiology, diagnosis, and management of PAH, with a focus on clinical and patient-centered care. We will have time at the end of the webinar, so please submit your questions using the chat function. Let's get started.
Welcome everyone, and thanks for joining us on this pulmonary arterial hypertension webinar. We're going to be talking about the definitions of pulmonary hypertension, the epidemiology, the World Health Organization pulmonary hypertension classifications, the mortality, the management, and the patient referral. So this is a common case presentation that we get on first-time patients who present with pulmonary hypertension. So we have here a 50-year-old female, presents with dyspnea on exertion over the past few months. Symptoms worsened despite inhalers. She had an echo done, EF 75% of the left ventricle, normal size and function, but the RV appears severely dilated, mildly reduced function, and the PASP, or the pulmonary artery systolic pressure, is 60. She may or may not also have a CAT scan of the chest, where the radiologist says there's a dilated pulmonary artery trunk, which can be consistent with pulmonary hypertension. So what do you do in this situation? A, you do nothing because the LV looks fine. B, you prescribe a calcium channel blocker. Easy to prescribe, let's see if it works. C, prescribe sildenafil. It's a cheap vasodilator. Or D, refer to cardiology because RV is a weaker LV. And last, E, begin workup to better characterize for pulmonary hypertension. And I'm being facetious with these options because I've seen all four of these done. So hopefully after these presentation, we can kind of narrow down the management on when you see an echo like that for these patients. So the reason we're not really sure what to do is because the right ventricle is also called the forgotten ventricle. These are the number of publications in the black bar that have been published over the left ventricle over the last 50 years or so. An enormous amount of publications versus the right ventricle in the gray bar. So not knowing what to do when the right ventricle doesn't work is kind of a problem all of medicine has. So left ventricle, I think anyone can treat, versus right ventricle, we're still trying to figure out. So I just wanted to go over some of the nomenclature real quick. First, primary versus secondary pulmonary hypertension. I'm not a big fan of this type of definition because I'm going to go over on the next slide on the different classifications. Second, pulmonary hypertension versus pulmonary arterial hypertension. So pulmonary hypertension, or PAH, is an umbrella term. It just means the pulmonary artery pressure is above 20. Versus pulmonary arterial hypertension, that is implying that the pulmonary arterial pressure is above 20, the pulmonary capillary wedge pressure is less than 15, the pulmonary vascular resistance is above 2, and you're suspecting a primary destruction of the pulmonary arteries. Or in other words, this is a WHO Group 1 classification. So looking at this image on the right, the pulmonary artery is this highlighted artery right here. So it's right after the right ventricle. And to get these measurements, we do a right heart catheterization where it goes through the SVC, through the right atrium, right ventricle, and then into the pulmonary artery, and that's how we get these numbers. So this is the first classification for pulmonary arterial hypertension. This is group 1. And ruling out some of these causes is where I start my management. So the top of the list here, you can see connective tissue diseases. The most common connective tissue disease that's associated with pulmonary hypertension is scleroderma, but I've also seen rheumatoid arthritis, lupus. I've seen systemic sclerosis as well. So I always send those labs. HIV, portal hypertension, I always send hepatitis and LFT labs in pulmonary hypertension patients. And then schistosomiasis is the most common cause of pulmonary hypertension outside the United States. And some of these heritable gene mutations, I don't send unless all these come back negative. And the reason, and drug and toxin, which I'm going to get to next, but the reason why this is all classified as group 1 PAH is because there's a specific pathophysiology that happens. You have here a normal pulmonary artery here, and you get kind of this progression of the pulmonary vascular disease. So you get vasoconstriction, and you get smooth muscle hypertrophy. And the hallmark lesion for pulmonary hypertension is this thing called a plexiform lesion, which develops on the pulmonary artery. And you get in situ thrombosis. And this is really what causes the elevated pressures in the pulmonary artery, is this plexiform lesion. And this happens exclusively in PAH. And the drug and toxin chart, here's the associated drugs with pulmonary arterial hypertension. The top four are these weight loss drugs that were used back in the 90s. And then dasatinib is used in leukemia. Toxic rapeseed oil, that was used as a cooking oil in Spain in the 80s. But by far, the most common drug that causes pulmonary arterial hypertension is methamphetamine. The methamphetamine epidemic has really blown up in the past 20 years. Here, this is a graph kind of showing methamphetamine overdose between 2011 and 2018. And you can see here, there's a start here in the West Coast, here in Albuquerque with Walter White, and then it really shifts over and into the Midwest and almost into the East Coast and the Southeast areas. So, and this is just from 2018. The epidemic has, as I'm sure you guys have seen in clinic, has just gotten a lot worse here in the Midwest and Kansas City in general. And this is a chart where patients' percentage who have methamphetamine amongst the PAH population. So in Kansas and Missouri, around 12% of patients who have been diagnosed with PAH have methamphetamine. And I'll say this number is more on the conservative side. In my clinic, especially where we treat patients who sometimes have lower socioeconomic status or Medicaid patients, those patients are more likely to use methamphetamine. So in my clinic, I would say probably 50% of the PAH population is due to methamphetamine. I'm actually giving a grand rounds talk next month where we discuss not just the clinical barriers and that we deal with when treating patients with methamphetamine PH, but also the psychosocial barriers. Getting them to clinic, getting them to get these labs done, how we talk about cessation of methamphetamine, and we'll be talking about that at the grand rounds next month. So second group is pulmonary hypertension due to left heart disease. So as a pulmonologist, I'm trained to blame the cardiologist anytime something's affecting the lungs. So I'm always looking for left ventricular systolic dysfunction, left ventricular diastolic dysfunction, and any valvular heart disease. And this is the most common cause of normal pulmonary hypertension. Next is group 3 disease, pulmonary hypertension due to lung disease or hypoxia. So here, COPD and ILD are the most common causes. I also refer all my patients to the sleep clinic because sleep disordered breathing or sleep apnea can cause pulmonary hypertension. And alveolar hypoventilation disorders is right down here. So like OHS can cause pulmonary hypertension as well. So I refer all my patients with pulmonary hypertension to the sleep clinic for a sleep study. And then group 4 is chronic thromboembolic pulmonary hypertension, which is a complication of pulmonary embolism. And group 5 is kind of a miscellaneous group. It contains a vast array of different disorders. So vasculitis, sarcoidosis, sickle cell is in here, renal failure on dialysis is in here as well. So we're really not sure the exact mechanism for group 5 disease, but these 5 groups are really like the 5 commandments of pulmonary hypertension. And anytime I see pulmonary hypertension suspected on an echo or on a CAT scan, I'm going through these 5 groups and trying to rule out each thing that could be contributing to the pulmonary hypertension. Now, the reason why I don't like primary versus secondary is because of these groups exist. So scleroderma is an autoimmune disease that can also cause PAH and cause the plexiform lesions. So you can have group 1 pulmonary arterial hypertension from scleroderma. Scleroderma can also cause diastolic dysfunction, which could cause group 2 PH. Scleroderma can also cause interstitial lung disease, which can cause group 3 PH. And scleroderma can also maybe cause hypercoagulability, which can cause PEs, which can cause group 4 PH. So this is why the classifications are so important and why we've kind of moved away from the primary versus secondary pulmonary hypertension nomenclature. So high pulmonary artery systolic pressure on an echo does not mean pulmonary arterial hypertension. This was a study done in Australia where they took randomly 10,000 random patients and did an echo on them. And 963, so about 1% of them had an elevated pulmonary artery systolic pressure of greater than 40. So when those 1,000 patients were worked up, 2/3 of those patients, so 67%, had a high PASP due to left heart disease, and only 3% had a high PASP due to PAH. So PAH, in relativity, is a rare disease. Now, the prevalence changes based on the global population. So the prevalence is 1% amongst the global population, but amongst patients with scleroderma, 12%. Amongst patients with heart failure, 40% have pulmonary hypertension. 5% of patients with HIV have pulmonary hypertension. Methamphetamine users, we're not sure. Some experts say 20, 30%. Some say 40% can develop pulmonary hypertension. So that's still being studied. And the reason we care so much is once you're diagnosed with pulmonary hypertension, it has a very high mortality. Median survival for untreated PAH is almost 3 years. And this is a graph for patients with scleroderma with and without PH. So the green graph here, these patients with scleroderma without PH, they do pretty well. They have a pretty long estimated survival probability. But once you're diagnosed with pulmonary arterial hypertension with scleroderma, your survival probability falls off a cliff, and you have a 45% 5-year survival probability. And same thing with sickle cell. Patients with sickle cell live well into adulthood into their 60s and 70s. But if they have pulmonary hypertension along with sickle cell, their estimated survival probability also takes a dip. So why is there such a big difference in prognosis between pulmonary hypertension and systemic hypertension? And it's really the ventricle that they're affecting. So systemic hypertension affects the left ventricle, and pulmonary hypertension affects the right ventricle. And there's this notion that the right ventricle is a weaker left ventricle. And I would argue against that. I would say the right ventricle is actually a different organ than the left ventricle. And the reason I say that is, for one, they're embryologically different. The RV and the LV, they arise from different origins. They're structurally different. The LV is more of a concentric shape versus RV is more of a crescent shaped. Here is a peristernal short axis. So we cut the heart from the top to the bottom, and you see this view right here. And here you could see the LV also very thickened. It's almost 10 millimeters thick versus the RV is only 2 millimeters thick. And on the left side here, the fibers are, the muscle fibers are different for the LV. They're circumferential fibers, and they cause kind of a torsional contraction versus on the RV, they have longitudinal fibers, and the contraction is a lot more simpler. And they're functionally different. The right ventricle is much more compliant and expends a lot less energy than the left ventricle. And so what happens when you increase afterload, or in other words, cause hypertension? And what does that do to the stroke volume to the left ventricle? The left ventricle is able to adapt. When you go up on the ventricular systolic pressure, the left ventricle, the stroke volume only decreases by maybe 10%. What about if you increase the afterload for the right ventricle? Just small increases in that pressure have a huge effect on the stroke volume for the right ventricle. And this is the primary reason why pulmonary hypertension causes right heart failure, is this effect on the right ventricle. So we're going to go over some images. This first of all, I just want to orient everybody. So here we have an ultrasound probe. We point it towards the mid-clavicular line, and we point it up towards the right shoulder. And the heart is shaped this way in the heart, or in the chest. And imagine cutting an orange with a knife and trying to slice it in half. And you get a cartoon picture like this. Here's the right atrium, right ventricle, left atrium, left ventricle. And on the ultrasound, you get something like this. So the right ventricle here is about half the size of the left ventricle. Same with the right atrium, half the size of the left atrium. And when a patient with severe pulmonary hypertension comes to clinic, this is one of my clinic patients, you see something similar to this. Very enlarged right ventricle. It's almost compressing the left ventricle. Very enlarged right atrium as well, almost compressing the left atrium. You can also see the movement here is a little stunted. We look at this area right here to see how well the right ventricle is contracting, and it's really not moving too much. It's moving here, maybe just a little bit here. And then this is the patient 1.5 years after starting treatment. And you can see Very good movement here. Nice up and down movement of the right ventricle. The right ventricle is almost half the size of the left ventricle now, and it's how it's supposed to look. Same with the right atrium, half the size of the left atrium. And this is the main reason why pulmonary hypertension is such a has such a high mortality rate, is because its effect on the right ventricle. So the symptoms that you look for, they're really twofold. One, you're looking for symptoms for decreased perfusion from the narrow pulmonary artery. So symptoms you get really overlap with other diagnoses as well. So dyspnea, lightheadedness, syncope is a late stage finding for pulmonary hypertension, chest pain as well. And then you also get symptoms for enlarged right ventricle. So increased venous congestion, lower extremity edema, hepatic congestion, ascites. And what this leads to is this kind of cycle that is really difficult to control. So you have this increased RV afterload, which causes a decrease in RV output, which causes a decrease in LV preload, which causes a decrease in LV output. The afterload also causes an increase in the wall stress, which causes RV ischemia, which contributes to the decreased RV output. The increased afterload also causes increase in RV dilation, as you guys saw in the echocardiogram that we just showed. That also contributes to the wall stress, and that contributes to tricuspid regurgitation as well, which all decrease RV output. The RV dilation also causes the septum to move. Imagine the RV and the LV being in a small Manhattan apartment. So once the RV is dilated, the LV suffers. So you get reduced LV preload, and you also get reduced LV contractility because of this as well. The decrease in LV output causes decrease in the right coronary artery blood flow, and this cycle goes round and round until ultimately you're diagnosed with cardiogenic shock. And then sometimes, actually a lot of times, when these patients come to the ER, they get fluids. So the fluids contribute to the cycle by causing RV dilation, or they get intubated. And when you get intubated, it causes vasodilation. So instead of getting blood flow to the heart, they're getting blood flow to non-essential organs like their kneecaps and their extremities. And this goes round and round. And ultimately, the reason for mortality in these patients is RV failure. And this is notoriously known as RV death spiral here in the ICU, and it's the main cause of mortality in these patients. So what can we do when we see these patients in clinic to prevent kind of this progression of disease? So one is really medical symptoms and signs of PH. So medical symptoms, basically the risk factors from the different tables I showed you. And then signs of PH are the symptoms I showed. They're all very nonspecific. But if you have a suspicion based on the risk factors, you start with easy testing like chest X-ray, a BNP also helps, and then ultimately going to an echocardiogram, and that helps raise your suspicion for pulmonary hypertension. So if the risk factors are there and the echo findings are there, usually I recommend a fast track referral for these patients if they have a high probability for PAH to a PH center. And at the PH center, that's when we decide if the patient needs a right heart cath or not. After we do a right heart cath, that's when we discuss what management or medications to start. So this is a study from 1990 where they started patients on a calcium channel blocker. And so there was an arm that didn't receive calcium channel blockers. And as you could see, very poor survival in this group. And the group that did receive calcium channel blockers, they did really, really well. So what this showed was maybe it's not important to reverse this plexiform lesion, but instead to just cause vasodilation, so it eases the burden on the right ventricle. So since then, there have been some pulmonary vasodilators that have come out. So epoprostenol was the first IV pulmonary vasodilator to come out in 1995. And since then, we've had many other pulmonary vasodilators released. Some are oral, some are inhaled, some are sub-Q. And the question is, has this made a difference in mortality? So this is the NIH data. So 1-year survival for pulmonary hypertension patients, 68%, 3-year survival of 48%. And this is some more pulmonary hypertension registries 92% survival after 1 year, and 74% survival in 3 years. So these medications do help in specific set of patients. And those patients are really these categories right here. So group 1, PAH, group 4, CTEPH, and then a subset of group 3, those with interstitial lung disease causing pulmonary hypertension. So these 3 groups of patients have all shown benefit from pulmonary vasodilators. Now, I'm sure you're asking, the left heart disease was the most common cause of pulmonary hypertension. What about them? And there have been many clinical trials, many studies studying different pulmonary vasodilators for left heart disease, and they all kind of show the same thing. This is a study doing where macitentan was studied in pulmonary hypertension due to left ventricular dysfunction, and this study was stopped prematurely due to increased mortality. Here's another one, tadalafil. It's a pulmonary vasodilator that was studied in patients with heart failure and preserved ejection fraction. This study was also stopped early because of increased adverse events of pulmonary edema. And this is another pulmonary vasodilator, iloprost, that was studied in COPD, also stopped early because of worsening functional status, worsening hypoxia, and worsening symptoms. So there's a very small subset of patients that benefit from pulmonary vasodilators, and that's really what our job is in the pulmonary hypertension clinic, to delineate if there would be harm from pulmonary vasodilators or benefit from them. So in summary, we discussed the risk factors for PAH. Methamphetamine and connective tissue disorders are the most common causes that I see in my clinic, and how it leads to right heart failure. And we discussed the high mortality for untreated PH from right heart failure. And last thing I want to talk about was referring to a PH center. So here at University of Health, we started our pulmonary hypertension clinic about 1.5 years ago. You can find the phone number for our pulmonary office on our website. But we're seeing new consults, and depending on the urgency and the severity of pulmonary hypertension, they could be seen as early as within 2 weeks. And we perform right heart catheterizations here in our hospital. And we also monitor, titrate, and start the pulmonary vasodilators. There's a lot of behind the scenes that goes with that as well. There's a lot of prior authorizations that go with it, talking to insurance companies. The pharmaceutical companies also recommend monthly pregnancy tests, as all these medications are very teratogenic for our female patients. So having a PH center kind of monitor these pulmonary vasodilators is very important. And then lastly, I try to do a collaborative effort with the patient's pulmonologist if they already have one established on treating patients' pulmonary hypertension. So we really work together on helping this patient's many pulmonary diagnoses, whether that being COPD, pulmonary hypertension, asthma, what have you. But thank you.
Thank you, Dr. Paroya, for joining us with that very insightful information. And we are so pleased to have the doctor here with us today to answer a few questions. So remember, if you have questions, you can submit them through the chat, and we will get those questions to Dr. Paroya while he's here with us. So let's see what we have. Our first question for you, doctor, as a primary care physician, what should I look for in diagnosing PAH?
So for one, thanks for having me. I think getting the word out for pulmonary hypertension is pretty big. Not a lot of people know about it, and we're still learning about it. So diagnosing and trying to find the patients who have it is a little difficult at first because the symptoms are very nonspecific, right? So shortness of breath, many things cause shortness of breath. Asthma, COPD, heart failure, they all cause shortness of breath. So trying to delineate pulmonary hypertension from those other comorbidities, it's kind of a little nuance. So the patients who we really look for are the patients who have that asthma diagnosis or have that COPD diagnosis, but they're not getting any better. So it's been 1 or 2 years, they've been taking the inhaler, they've been taking their medications, and their breathing is getting worse. So those patients, they really probably need to get some more studies done to see if they have some of these rare diseases like pulmonary hypertension.
See, that reminds me of even patients, what should they look for in themselves? If they say, I've been talking to my doctor, nothing's getting better, how should they look within themselves to find?
Yeah, so the biggest thing is really the risk factors. So do they have the risk factors to develop pulmonary hypertension? So do they have an autoimmune disease? Do they have a drug history? Have they ever taken chemotherapy in the past? Do they have other comorbidities like COPD or heart failure? So all those comorbidities and kind of risk factors play a role in pulmonary hypertension, and if you have it or not. And as far as symptoms to look for, it's really, like I said before, shortness of breath, that's not getting any better. Some uncommon symptoms are also lower extremity swelling, chest pain, and bloating as well. And passing out is usually like a late stage sign, and usually kind of a marker for more severe disease.
Absolutely. Let's see, what else we have. When should I refer as a primary care physician to a pulmonary hypertension specialist?
Yeah, that's a good question. So I think any primary care specialist is able to do the initial workup right in their office. So what I recommend is getting the blood work done, getting a BNP level done to see if there's any stress on the heart, and getting an echocardiogram done. And that'll give you a pretty good idea if the patient has pulmonary hypertension or not. Now, if the echocardiogram is positive and the patient has risk factors for pulmonary hypertension, I think that's when you should send the patient over to a specialist for a referral.
Great. Let's see here. When patient population, what patient population should I screen more aggressively for PAH?
Yeah, that's a good question. In my clinic, maybe like 40 to 50% have pulmonary hypertension because of methamphetamine use. So there's a debated topic: should all patients who have methamphetamine history should get screened? My opinion is yes. I think they should all get like an echocardiogram done. And then other patients are patients who have like scleroderma, lupus, some type of autoimmune disease, HIV. Those patients should also get screened a little bit more aggressively than the normal population. And then also patients who have heart failure, they're already getting screened for that anyway. But I think patients who have COPD, especially severe COPD, they should be screened for pulmonary hypertension as well. So yeah, all those risk factors really do play a big role in kind of going through each one whenever you suspect or are thinking about pulmonary hypertension or differential. It does help a lot in trying to delineate what's causing it.
And so they can be together, like these PAH can be combined with multiple other diseases.
Yeah, that's what makes it difficult. For example, you can have methamphetamine use and you can have heart failure. So is the PAH being caused by group 1 disease or group 2 disease? And that's always difficult because the studies show that the patients who get medications and they have group 1 disease, they'll live longer. But the studies showed the patients who get medications for group 2 disease will not live longer. So that's really what we try to figure out in a clinic. Will the patient really benefit from the medication, or will the medication be more harmful for the patient? And that does make it tricky. And it's usually we do a case-by-case basis, and it's definitely a multidisciplinary approach. So I talk to the patient's cardiologist, I talk to the patient's primary care doctor, I talk to the patient's rheumatologist as well, and we really try to make sure that we're all on the same page when treating these complicated patients.
Okay, let's see, we're almost out of questions, but there is one that talks about the labs that you should request. Is echo enough to diagnose? What imaging is appropriate?
Right, so I think starting with an echo is really good. If you see evidence of pulmonary hypertension on an echo, then you can just send the patient for a referral. But to diagnose or to confirm the diagnosis of pulmonary hypertension, you need something called a right heart catheterization. So that's a catheter that goes like from your neck, it goes into your heart, and then it goes into your pulmonary arteries. And then that diagnosis confirms whether you have pulmonary hypertension or not. And we really do want to do that procedure on everyone who we have a high suspicion for, because like I said, only a subset of patients benefit from the medications, and a lot of patients don't benefit. So we really want to be 100% sure that they will benefit. So that's why we do that procedure. And we only do that procedure if our pretest probability is high for the disease.
And that would tell you if that person might be successful with that treatment.
That's 100% right. Yeah,
Right.
That's 100% right.
Interesting. Let's see. I think those are all the questions that we have right now. We are so grateful that you joined us for this. Thank you for this presentation. And if you do have a question and you did not submit it in the chat function, please submit it anyway. We'll send it back out to you. This webinar will be available on a video link, and we'll send that out to everyone who's registered. Again, thank you for joining us, and thank you, Dr. Paroya, for this very insightful presentation.
Thanks for having me.
Have a great day.